that at the last board we had a paper from Natasha, and because this is a matter of sort of keen importance to us all, we requested Natasha to come back and keep us topped up with progress in this area. So Natasha, over to you. Thank you.
Thanks, Mark. Hi, everyone. It's lovely to see you again. I will try and keep things very brief as it's only a short verbal update. As Mark stated, I obviously submitted my action plan to you guys at board in September. So my main purpose today was just to update you on that, really. The overall picture is that everything's progressing really well, I'm pleased to say. We will have the National Freedom to Speak Up policy planned to come to Workforce Committee and Board in January for sign-off and implementation, which is all on schedule. We also have our web app in testing phase from the Acute Trust now. So I'm also hoping that that's going to launch in January. We're just looking at a few things that need ironing out for our own purposes and branding, etc. So that's all going really well. Speak Up level of e-learning has been rolled out earlier than I expected. So that's gone out to all levels of staff as of the 1st of November, which is brilliant. And I just need now to get some reports built in terms of keeping track of how our compliance is going with that. With regards to champion recruitment, again, January is going to be quite busy because there's a lot of stuff that's sort of on track for January, looking to launch some refreshed recruitment to get more Freedom to Speak Up champions into the organisation. That'll be a slightly longer plan between January and March, but I'll certainly be starting from the new year. I'm just doing some work with our current champions around their thoughts on how we could make that a really supportive process and a meaningful role for everyone. A couple of points that perhaps weren't in the action plan. So we've also needed to get up and running with completion of the Freedom to Speak Up reflection and planning tool to assess our arrangements for speaking up in the organisation. But again, that's all in process now. We've got some senior leadership focus groups in November and December with a review planned for January and further planning. And also just to update you guys that October was Freedom to Speak Up month, as I'm sure you're aware. The theme was breaking down barriers. We kept things fairly low key, with me still being fairly new into post in terms of the planning and execution of that. So we focused on increased promotion and engagement, which was part of my action plan anyway. So that went really well, and that promotion and engagement is continuing until the end of the year, and then there'll be some new plans from next year as well as how to sort of keep that momentum going. So that's all I wanted to bring to you guys, really. Things are going well, things are busy. If there's any questions, let me know.
Thanks, Natasha. Tessa.
Just a comment and a question which I probably ought to know the answer to, but I can't remember. One is I'm really pleased to hear that the app is progressed now at pace. I know it got delayed because of all the work that was having to be done around the Care Notes outage and so on, but really glad to hear that that's going forward now. Where are we at with capacity from the Freedom to Speak Up guidance? Probably a question for Elaine. I know we extended Natasha's hours. Has that become substantively increased, or are we still on temporary additional hours for Natasha, Elaine?
It is still temporary. To your second question around champions and the capacity of the champions, we had spoken about this, and for the time being, Natasha's holding the more complex cases that she's dealing with. When we're at a place where there's a little bit more confidence in more routine things that our champions can take up, then we're going to review that. That's the current position.
Thank you.
Thank you, Tessa. Well, that was quite a positive report, Natasha, in terms of what's moving forward. And I think most of us have, if not all of us on the screen, have met you and know that positivity in progress certainly comes from the positivity that you bring to the role. And I've said it before, but please be aware that you've got the full support of everybody on the screen here, your entire board in the work that you do. I know you report regularly through to Tessa, and I suspect more so Vina as we move through the months ahead. in terms of reporting to board, there'll be a standard sort of time per year that you come back once, twice, 3 times per year. And I don't want to stipulate that at the moment because we're still in that building phase, but I'll certainly look to the workforce committee and Tessa to start advising what that should be, because this is a subject that I think we need to keep regular tabs on the activities. There's 2 aspects. There's the activities within the Guardian role, and then there's the how we're developing and building it to make sure that it's promoted across the trust and it's used effectively, and there's the closing of the loop and all those other things. But I think we leave that on your plate, Tessa, for discussions in your committee along with Natasha, because we always look forward to hearing how we're doing it, because it's such a critical part of what we do. If nobody's got any other,
thanks, Mark.
Nobody's got any other questions. Natasha, thank you very much. Short and sweet, but I think that plays to the knowledge we have of the activities that you're doing and the positivity you bring to the role. So thank you very much. And we look forward to seeing you either again here or at the Workforce Committee, whichever comes up first. Thank you very much.
Thank you, guys. Take care.
Thank you. Bye now. We move on to our routine regular reports now through the committees and activities. So if we start with Janet and perhaps John on Q&S and quality. Thank you.
Okay, thank you very much. Yeah, I will keep it brief because I am mindful of time. Just a few things I wanted to pick out of this on this report. The first was around our discussions around performance report and the need for a recovery plan around staff inclusion, our results around that. And we had quite a long and detailed and actually really useful discussion about whether that recovery plan should be overseen by the Quality and Safety Committee or the Workforce Committee, bearing in mind the interrelationship between the amount of staff you have and how engaged they are and the quality of, how that impacts on patient quality. But we agreed that actually, because Workforce was actually overseeing all the other workforce indicators, it would make sense, particularly in light of the comments Tessa made earlier around how complicated everything's getting, if Workforce actually oversaw that one as well. So I just wanted to highlight that discussion. Going on, just briefly then, in items for committee assurance, you'll see there's a great big long list there. A lot of those are in the summary quality report, which I think John is probably going to comment on in a bit. But the only one I wanted to pick out in particular on the ones from the quality report was the one around mortality and learning for deaths, because you'll notice that's down as a level 1, not because we have concerns about our mortality rate or the data or even the learning around that, but because of the new group that's been set up and how that actually is yet to meet or is just met for the first time. So I wanted to just assure you on that one. Just going on, the other one I wanted to pick up again for assurance for the board, because the way it's written is the update on risk assessment and risk management, which we gave level 2 and said the current policy and process doesn't meet national guidance, because given the discussion we've just had about risk management, you might worry about what that refers to. And in actual fact, it refers to our risk assessments of patients with mental health or learning disability. And we use a tool called GRIST, which I hope nobody's going to ask me what it stands for. But the first word is Galatean, which always sounds like something out of Star Wars to me. So I think the other words are around risk, but one of the clinicians will I'm sure tell you if people want to know. But basically that risk assessment puts grades in of low, medium and high, and national guidance is we should no longer do that. That's not appropriate. So while we're working on a solution to replace that tool, in the interim, clinicians are using a narrative. So the work on that is ongoing, hence the level 2. And I think the final thing I wanted to pick out was around lockdown mitigation. Again, that's around lockdown in our particularly in our community hospitals. Should we need to lock down? It's not around any other lockdown that we've become familiar with. And actually, we're having a paper coming back around that, looking at risk and mitigation in a bit more detail, particularly given, I think, the discussions as a board we've had around risk appetite. So that was just the few items I wanted to pick out. And I think under this item as well, there is the quality report, which I think either John or Hannah will probably speak to.
Thank you, Janet. And then if there's anything at the end, we'll move to questions across the lot. So John, Hannah, or Tori's with us as well, I think. So whomever, please.
Yes, thank you. I think Janet's covered most of the important bits, and I'll take the quality and safety report as read, and it was considered in detail at the quality committee. I think Janet covered it slightly, just to reassure people around the mortality assurance scores that are given. The mortality oversight group now comprises of 3 different elements to it. One is the learning from deaths, or the mortality review process. The other one is the suicide prevention strategy and implementation of the plan. And the third bit is the end of life care plan, strategy and implementation. So what I can assure board is that our learning from deaths process has always had very high levels of assurance, but the low levels of assurance is because we are revising our suicide prevention strategy with the new national strategy being recently published. Plus, in terms of the end of life strategy and plan, that's been that was suspended for some time now, and we are reinvigorating that particular strategy and implementation. So just to assure board around the assurance levels provided for that. Nothing more to add, Mark. Thank you.
Thank you, John. Does anybody have any questions around any of that? I do have one. And I don't want to get into the detail, Janet, but when I read the quality and safety report, when I read about the medicine incidents at Hillcrest and what looks like quite a dramatic or alarming amount that's there, can I just seek assurance that the committee has discussed that and sought relevant reasons and rationale as to why that is the case, and to be satisfied that actions aren't needed? I see
Good question, Mark. We did have a discussion around the pharmacy, and I think probably I reported at the last board actually that there were quite a lot of actions that were required, and we have asked Andy Downs, Tony Downs, to come back to the next meeting to report back on that. Yeah.
Okay, great.
But can I just say that there are wider issues than just the Hillcrest. I have to be honest on that. I can see Tori wants to come in as well, which is helpful. But it's not just the Hillcrest issue. There are issues. There are other issues as well that we needed to have reported back.
You'll understand when I see the words Hillcrest and medicine issues and patient safety, it can just seek some additional assurance that we're on top of it. So, Tori.
Thank you, Mark. I think in the report it's not clear because the 2 sentences are separated, but they reported 19 medication incidents, however 18 of those related to one patient and concordance issues with that one patient. So that goes some way to explaining why the number was significantly higher than normal.
Okay, thank you very much. And I think John was probably going to say the same thing because his hand's gone down, I guess. Okay, thank you very much indeed. If there's nothing further on that, then if we could move then to workforce issues, including the 6-month safer staffing report. Tessa.
Yeah, thank you, Mark. Just some very quick points because it is all contained in this, and I'm sure Elaine will pick up anything that needs more detail. We had a really useful staff story at our committee this month, which actually looked at the issue of the application of HR policies and processes from a management perspective and the challenges that our managers face when an allegation is made against them, goes through due process, is found to be unfounded, and then they have to go back into the workplace and continue to manage the person that's made the allegation against them. A really useful conversation and some actions to take forward to make sure we're ensuring we support the managers as well as any member of staff who obviously has a right to make a complaint or raise a grievance, but also conversations about how we support members of staff who are maybe frequently raising concerns, none of which can be proven, and how we go forward with that. We were pleased to hear that new staffing establishments have been agreed for inpatient areas. Natalie reported that had a very positive impact on staff morale, although of course it still leaves us with a vacancy issue and recruitment challenges. But actually the fact that they now know what their staffing should be and they feel that they've been listened to has had a very positive impact. All SDUs had reported that turnover was down at the integrated governance meeting, which I found to be a very interesting nugget of information. We need to triangulate that against other factors like recruitment and retention and so on, but that sounds like we've got some positive progress happening. The improvement plan is coming to the Extraordinary Workforce Committee in December, and Scott has agreed to do a cross-referencing, if you like, of probably not the word Scott would use, but to ensure that the actions from the people plan and our recovery plans are all marrying across, and that we're not reinventing wheels, but actually using the actions that we're agreeing to deliver on the issues that are out there. Recovery plans remain a challenge. I notice it says that we didn't allocate some levels to some of our recovery plans. In actual fact, we just didn't change the levels apart from one, which went from a 2 back to a 1. So the others were all level 2, and we have got 4 additional ones that will come to the January meeting now. So Charlie Windsor has very kindly agreed to sit down with Elaine and key members of her team who are responsible for the recovery plans to do a, if you like, this is what good looks like. And we know it's challenging with the workforce ones because we haven't got monthly data like waiting time data that comes in and answers the question. So it's looking at how we track and monitor progress using other things. The 2 monthly pulse surveys will help, but only if we are able to keep the level of engagement going with staffs. And so I think that's going to be critical for our progress going forward. And then we heard the term the Arise plan for the first time at Workforce Committee, and I think several members of the committee looked a little bit blank because we didn't know quite what Arise was or what it stood for. However, I think it's really crucial that we realise that this is our key priority, and we need to have a really detailed look at that in the January committee in light of the improvement plan work and so on. So I think the strands are beginning to come together. And my final comment doesn't come out of what Workforce Committee has done, but a piece of work that will relate to the Arise process around recruitment. Matthew very kindly asked me if I'd be part of the recruitment focus groups for his associate director last week. And one of the other panels was an Enrich panel. And I asked the chair of the Enrich panel to feed back to me what their thoughts were as to how the panel worked, to ensure that people from different ethnic backgrounds or disabilities had an opportunity to influence what we were doing through the recruitment process. Thean has very kindly done that, and I'm going to pick that up with Elaine so that we can feed it into the people plan and the recruitment process. So that's very positive, I think.
Thank you,
and
Tessa.
I'll pass over to Elaine for the rest.
Well, I was just going to say on that one, if there is some learning around panels and recruitment, you might want to pop it to Jill and I pretty quickly with regards to the recruitment of our new chief executive. If you think there's anything pertinent there, then we absolutely need to know about it, because Jill is in the process of setting up panels and we'll be going through that process. So if there's something pretty key, to get it to Jill quickly. Thank you.
Yeah.
Jill, did you have
forward the email from Thean to Jill so she can see what the feedback was.
Thank you very much. Jill, did you have a question before we move to Elaine?
It was a statement, actually. One of the papers that did go to Workforce Committee, but actually Workforce Committee had some questions about and wanted some clarification, was the annual organisational audit, which is the statement that John, as responsible officer for doctors, is required to complete, and then it's actually signed off by Sarah as chief executive. And I know there's been discussions after Workforce Committee as a result of the issues raised, and some revisions have been made to that, which I now understand Sarah's happy with, because obviously she signs it off. And just for confirmation, it is in the papers as at the end of the papers, starting on page 296 of Diligent, and so that's the revised paper that Sarah's going to sign off and then submit. But I just thought I'd mention it because it had been to Workforce Committee and there were some concerns about it.
Thank you, Jill. Thank you for that update. Elaine, do you wish to take us through the workforce paper?
Yeah, I'll take that colleagues have read the summary report, but if I take the key issues around staff turnover, monthly sickness and absence rates and appraisal rates, which are down against our projected targets. Interventions that we're taking around staff turnover is really dialing up, ensuring that we have those stay conversations in a more timely fashion with staff, ensure that we're addressing issues around flexible working or other matters that staff might have that we're able to legitimately and make a considered response to. Sickness absence rates, it's ensuring that those conversations take place with staff who've had a period of 28 days or more of sickness, and having conversations about how we might encourage them to stay in work or return to work in a timely fashion. Around appraisal rates, we're ensuring that managers are considering different ways to have appraisal conversations where they have staff members that have broadly similar roles, explore the options of looking at team objectives, which doesn't negate the fact that individual conversations should take place as well. Around employee relations, we currently have at the end of September 2 outstanding disciplinaries, 2 grievances and 4 acceptable standards of behaviour cases going through the HR system. We're working these through as quickly as we can, again, without protracting the process, because as we know, it has an adverse impact on the employer-employee relationship. Just on the matter of the National Staff Survey, we know that that's out at the moment. As it currently stands, our return is 40%, so around 1% higher than it was this time last year. We had quite a conversation on Tuesday at SLT about any initiatives, things that we can do to increase that. I think everyone's taking that to heart and looking at even including coffee break, and the coffee break is use the activity to complete your National Staff Survey. So we're trying to get quite innovative about it as well. Just on the matter of apprenticeships, it's already been referenced. We have around circa 170 apprentices in trust. We're also looking at expanding that, which is something we will bring back at various points to execs and to a workforce committee. So we're dialing up again our footprint in that space. On implementation of the people strategy, a lot of what we're doing, my observation would be that speaks a lot to our improvement plan. We're very aware of the strong feedback that we've had around our HR policies, our systems and processes around our people management piece. A key thing that we'd be looking to integrate into our next phase of the improvement plan is also the integration of the restorative and just culture approach, streamlining of our policies as well as the support that we've been talking about already around upskilling our leadership teams and our managers, but also supporting, I believe, our HR team to work differently, increasing our digital footprint where we can, reduce the paper trail. I think as we've already rehearsed this morning around reducing the time to recruit, it's also in focus. The reset around the attraction and retention, arise meaning attraction, retention, induction, introduction when people are moving into new roles. So it made me forget the R, but the support and staff experience. That's what ARISE stands for, with the 2 I's. We're aware there's an enormous amount of work to do. It's about prioritising, which I think we've already mentioned earlier on in this meeting. We're keeping our eye on the ball, but there is recognising there is a lot of activity in this space at the moment. Phase 1 of the improvement plan is very much about positioning the cultural change and establishing the behaviours across the trust for all of our staff, and then moving into phase 2. But I'll take any questions. Sue.
Thank you, Elaine. Sue.
So the first is really a question of Scott, and that is to know whether the the employment of bank staff has an impact on morale on staff who are employed permanently by the trust. And the second is really just a comment about statistics. So the unemployment figures for Herefordshire are 2.8% and Worcestershire 3.7%. So you're not looking at places where there are a lot of unemployed people. But what you have got are a lot of economically inactive people. So you've got 20.7% in Herefordshire and 16.6% in Worcestershire. And it's reaching to those because many of them will be former NHS staff. And when I go on social media, I don't see that we are followed by the sort of figures that I would expect us to be. So, for example, on Twitter or X, as you might call it, when there is an advert, it doesn't get very much reaction. I mean, sometimes it's got 84 people are seeing it. And that's not what I'm used to, even in employing just a single school role. And I just wonder if there are areas where there are people we need to reach out to, bearing in mind that we are a good employer in terms of flexible working, who might come back on board and cease to be economically inactive given this current crisis in the economy, but we're somehow not reaching them and they're not understanding what benefits we offer.
I'll attempt to answer some of your questions, Sue. There was a lot in it. But essentially, I think there's a great opportunity for us to look at what our local data tells us about who our potential employees might come from. And then the challenge for us is to adjust our approach to engaging them. So not everyone is going to go on NHS jobs. I think there's an opportunity for us to make a greater use of social media. We hear in Trust that it's about where people go to look for that next job, and we have to be on board with that as well. I think there's an opportunity for us to simplify our application process. When you ask your average person, however we might define average, our actual application process strikes cold red in most people because it's quite long and it's convoluted. So there's got to be a way that we reflect that. We know that there are differing levels of literacy among some of our workforce, and our forms and our approach to appointing or recruiting needs to also reflect that as well. So I think in looking at the recruitment piece and where the jobs go to, there is more work that we can do in that space, definitely. And then there's something else you asked about. I don't know if Matthew wants to comment about the agency.
There was something about social media as well, and just to my colleagues that Sue's relatively new head of comms is listening in to the call. She's part of seeing what's happening at board, and I'm sure those comments that you made, Sue, won't be lost on Fee, who is obviously fresh pair of eyes looking at all our communications, both internally and externally. So I'm sure she'll be picking that up. Matthew.
I mean, first of all, on the temporary staffing issue, there is a body of national literature which correlates the higher use of temporary staffing with a decreased permanent staff satisfaction overall. And it's something that we've been talking about in our reducing agency group as well. So yes, we don't know about it locally, but certainly the national data tells us that. I was just going to raise a point. You've got a headline rate there of rolling 12-month turnover and a kind of point in time figure. Just to note, I mean, it's I guess not a uniform thing. In fact, in mental health services, overall turnover is within that's 10.5%, and it's improved from 17% at this time last year. Similarly, in children and young people services, it's only 10% turnover, and again improved consistently from 15% last year. So there may be some positive signs in some areas that if we're retaining staff better, actually some of this workforce gap starts to close up.
Yeah. I recognise there have been some specific initiatives in areas where it is definitely levelled the workforce. Yeah, thanks. Oh, Scott.
Sorry, Scott, I was going to say thank you, Matthew. It's always wise to remind ourselves occasionally of the successes we do have, because in Elaine's agenda, it's large, it's complex, and it's really, really difficult. and we naturally focus on the problems, but occasionally there are some great successes. So thank you, Matthew, for bringing that to our attention. Scott, quick comment.
Yeah, I mean, just pick up a couple of your points there, Sue. I think that in terms of where our teams see things, so it picks up on some of Matthew's themes, really. You know, we've got quite a few teams who have a strong local identity, and they really value when people are part of that. And I think the challenge for us, and with those areas which have been a success, it's about we've enabled that local ownership and that local drive. There's some fantastic examples from some of the community teams, for instance, up at Redditch Bromsgrove area, where they really drove that local recruitment. And it's those kind of best examples that we've started to collate and trying to build the environment where everybody can do that kind of thing. And there has been those genuine successes. I think in terms of the other point you made about reaching out to past workforce, obviously we did a lot of work in that space during COVID. There was quite a lot of feedback from those groups that it was initially difficult for them to get over the organisational barriers to get into work in a simple way. During COVID, we relaxed as a system, as a nation, we relaxed some of those barriers, but those have come back up. As we move, and that they're perceived as barriers, but they're important factors in recruitment. But for us to access that workforce, we have to do the workforce checks, the onboarding process, the flexibility. We need to do that as simply as possible. But that workforce is out there and willing to be part of this if we meet them on their terms.
Thank you, Scott. If there's nothing else, we'll note the reports from workforce. Thank you, Tessa, Elaine, and colleagues who are entrenched in that on a daily basis. And like I said, a very difficult arena. We'll now move on to finance and performance, and just remind colleagues that an AOB has been come out, and it's AOB because it's a national letter that only came out last week once the papers have been prepared. And I've asked Robert to bring what he can, which may not be too much at this stage, to be fair, to the attention of board today. And Robert, could I ask you to pick up the AOB under your finance report rather than leaving it to the end of the meeting, as there's obviously some synergy with finance, please. So over to Biraj first.
Thanks, Mark. I think the summary is very complete and covers most of the points that we discussed at the committee meeting. The key things I'd probably want to tease out, just 3 or 4 things, would be that, and you'll read that the system continues to be very financially challenged. But we, in month 6, it was a strong month for us. We posted a small surplus, which is in line with our plans. So that was very pleasing. Of course, as you just said, Mark, notwithstanding the item that we'll be discussing in a short while, which may well have some additional financial pressures for us to think about. We've always had a focus on risk, but we've changed our agenda at the committee, and we will do so for the future now, where we start with the discussion on our BAF and our risk registers, and that's to frame our discussions and steer the dialogue and the debate throughout the rest of the meeting around those risks, and it was very helpful on the last occasion. Clinical apprenticeships, we've approved, at least in principle at this stage, an increase in our investment in clinical apprenticeships. Again, crucial part of our plan in response to in respect of recruitment and staffing, and in line with some of the accolades that Sarah picked up on right at the beginning of this session. There's going to be full detail of that, which will, of course, in due course, form part of our budget setting process. And then finally, out of area placements, obviously a very hot topic nationally. We've started debating the position on this, looked at the key levers. We've got more detail that we'd like to see, and we'll be seeing the full recovery plan at our January meeting. I'll let Robert take on the detail around the finance and the performance piece.
Robert, are you there? Because you're frozen on my screen.
Yeah, I'm there. I can hear everyone. So
that's okay. I was just starting to worry. I thought, oh no, the director of finance is not here, and we're just about to have the finance paper. And I could see a few people then going into a cold sweat as to who I was going to select to present it. But you're frozen on my screen, but we can hear you. That's the main thing, Robert. So away you go.
Okay. Well, everyone's fine on my screen. I'll If it's okay, Chair, I'll pick up the performance part, then I'll move to the finance bit and bring in the AOB. I'll pause after the performance part for any questions, I guess, before going to the finance bit. So just in terms of the performance report, we have picked up some references earlier today in terms of some of the items that have come through on that. Beige has picked up one of the key national metrics around the out of area placements, and that really is an absolute focus that is coming down in terms of trying to get those patients, those mental health patients, treated in county. We are drawing together a recovery plan. Actually, as Matthew would say anyway, we are historically good at this, but we're seeing a pressure in our position, so that's something that we need to draw together. A couple of other elements. I've touched on the talking therapies, Mark, so I won't draw that out again, but the overall access rate remains a key issue. We are led to believe talking therapies will continue to remain a significant national target, particularly in respect to the beneficial impact it has on keeping people economically active, so helping people get back into work and the like. So there's a much wider social benefit there, which is one of the key reasons why it remains a very significant national target. The final bit I would want to draw out, really, other than clearly there's detail there around areas that we're going to draw plans together through the various committees, is we are starting to see some new metrics coming through for mental health service in particular. This is something that's been trailed for quite some time, but in terms of published data around longest waits for children's and adults, and in terms of some of the metrics around moving to some of the new standards around access and waiting time. So those are all really important issues. I think those are the key points I'd draw out on the performance report, Mark.
Thank you, Robert. I don't think there's anybody showing there. I think it's quite clear and concise, your report. And whilst I'm mentioning that, it's worth saying that our move to getting more clear and concise reports is variable. And I'd ask those who are responsible for commissioning and writing reports to consider in their mind the conciseness of the information to the priorities of the board and what we need to know. And I'll leave it there. Right, please carry on, Robert.
Yeah, thank you. If it's okay, what I'll do is I'll provide just to draw out the high points or the key points in the finance report, and then I'll draw into the letter because I think the context is quite important. So as Beach drew out, month 6 was actually strong performance from the trust in what remains to be a very difficult circumstances. I guess the key points I draw out is that we have two elements we're working with in terms of our position. So the underlying run rate decreased slightly, which was really good news. And actually what that is doing is that is allowing us to run at broadly a recurrent break-even position. That is what we're desperately trying to hold on to. And the fortuitous surplus part is around some additional income received on a non-recurrent basis at the start of this year. So that's there. I'll come to that in respect to the letter. The key elements to keep sighted on, though, around that are the two strands of agency or temporary staffing expenditure reduction. Matthew's our SRO, and what you will see from the report is we are continuing to make good progress on that, although we are a little bit behind plan. Encouragingly, this month we started to see some gains within our mental health services, which we'd flagged earlier were going to be the more difficult to draw down. Matthew and team have been making some really good progress. It's a team effort, so John is doing a lot of good work around medical, and Natalie clearly from a nursing perspective, but it's going to be something that runs. What we're all hoping for is obviously some of the benefits of the Arise programme start to kick in over the shorter and medium term, which then helps as well. So long discussion at F&P around that as well. The second part is efficiencies, and again, this is something that is we are challenged locally. I'm pleased to report that we are making good progress from our perspective for this year. A large element of our plan is around agency reduction, which you'll be aware of, and there's then a number of other elements around re-procurement and the like. You'll see from the F&P report some of the examples of some of the procurements we've taken through and made some good savings. So overall, we are on track to deliver our efficiencies and deliver those efficiencies that we set out to deliver recurrently, which is really important to say about that underlying run rate as we head to next year. We have the same challenges that most partners have. Inflation running higher than planned is a significant pressure. Industrial action, whilst probably less of a pressure for us than acute colleagues, is still there. And as we know, we're investing in some elements on the back of our quality improvement programme and other areas. So the year remains tight, but we are on track, and hence the outlook with the report. If I just briefly pause there, Mark, for any questions, then I'm going to pick up the system and then into the letter, if that's okay.
Yeah, thank you, Robert. Any questions at all? I don't think there are. Your report's very clear, and I think you quite naturally, as an understated Director of Finance, underplay what's happening here, which is there are not many trusts that receive financial reports like this year in terms of being on a very difficult plan to start with and keeping to a very difficult financial plan. And I think it's testament to Sarah and all the executives. You're the ones that manage this on a daily basis with your teams, and you are delivering as you said you would deliver so far, highlighted in brackets so far. But no, congratulations, Sarah, the team, Robert, for the oversight to do this. It's not easy, and you're doing it. You have a history of doing it, but the difficulty, as Robert keeps telling me, is ratcheting up and up as the years go by. So congratulations to all. Thank you very much indeed. There are no questions, Robert, so I think you can move to the national letter and on what you know at this moment in time and the implications. Yes. Thank you.
Yeah, so you have the national letter there, and clearly this is a very significant challenge and concern for NHS finances this year, which is set out there. The letter talks about industrial action. I would probably say the subtext is clearly that is the key driver here, but we do have a number of other factors which I've talked to, excess inflation being one of those that's also in there. Just stepping back, if I just draw the context in here, nationally finances are significantly under pressure. If you looked at our system position at month 6, these are published on the ICB website at the moment. They had their board meeting, but as of month 6, we had a system deficit plan of just under 22 million, and we're at 42.5 million deficit. So significantly off the plan, 20 million off plan, and actually the end of year plan is for a 19.2 million deficit. So the back 6 months of the year is more challenging, as we're expecting to be making some further gains, and obviously historically times of winter and the like bring other pressures. So our system is not by any means different to other systems nationally. We are experiencing pressures. The letter just reinforced the point that actually from a national perspective, clearly we need to manage the quality and safety of the service. We need to be ready for winter, and there's a whole raft of performance deliverables, not least waiting list recoveries and the like that we're seeking to do. But holding on to the public finances is clearly also a really important challenge. So where we are, and all systems are, is we've been asked to take stock, work back through our plans, and resubmit effectively an update position for next Wednesday, the 22nd of November, in terms of assurance around the operational delivery, particularly around winter, and the plans to manage our finances back to the plans that we set at the start of the year. So for our system, clearly that is challenging in terms of we have an adverse variance to plan this year to date of the 20 million that I referred to, and significant extra things to do to get back to the plan. That is work in progress at the moment. Just formally, we will be asking, or the system will be asking as a system submission for chair and chief exec sign off around that. So we're likely to end up with some sort of process of having to regroup outside of this board meeting. Obviously, I'll be expecting to keep all board members updated in terms of where we get to around that and where the system gets to. At the moment, my team internally are very much focusing on working through the detail of what we have set out and actually confidence around delivering our plan, or if there are opportunities potentially with system partners to deliver some more. So we're working through that at the moment. It is work in progress. I think that's all I can update at the moment usefully, Mark.
Thank you, Robert. And as I read it, our board will be required to sign up to the system plan, for want of a better term, before the 22nd of November. I think I'm right in saying that. And in which case, what would be the best method of doing that? Because that's, you know, we're talking across the weekend, Monday, Tuesday. I wonder whether board would agree perhaps for delegation of that authority to go to myself and Beej as chair of F&P, with Robert as the director of finance and Sarah as the chief executive, to get the four of us together, because it's not about our own finance per se. It's about agreeing to the ICB's collective proposal as to how we're going to get back on plan. Am I right in am I right in my reading of the letter in that way, Robert? That's a requirement of our board.
Yeah, that is correct. Actually, technically, it will be for chair and chief exec to sign off, but that is all clearly on behalf of the board. I think it's possible clearly people are aware of the governance. There's likely to be a submission and then probably some opportunity to route back round. But given where we are with meetings due to happen on Monday, Tuesday, I think your suggestion would be sensible. I'm more than happy to summarise as I have in the past and email around to the board to keep you all updated in terms of where we are.
Yes, I think I would like to widen that front. Yeah, it might be chief and chair to sign off, but I think bringing in Beej as the chair of F&P and yourself to have that joint conversation prior to sign off, and then with what we know of the plan, then an email around to all board to keep board up to date would be particularly useful. Sue and then Carol, please.
So wasn't there some thinking that NHS England was going to divest itself of staff, or there was going to be some changes there with the introduction of system working?
So NHS England are going through a significant process of restructuring and reducing their headcount. So actually, it's been an ongoing process for about 18 months or so, but that is all part of it. And that was actually a key component of the plan. What we don't know at the moment is the final outcome in terms of the relationship between the regional teams and ICBs, but that is significantly underway at the moment already.
Carol.
Yeah, I'm happy with the idea of delegating this. I suppose the assurance I'd like is around that balance between the finance and the patient safety and the impact of any changes that I'm comfortable with where we are as a board and what we're doing as a trust and all the conversations we're having. But it's just, I wouldn't like to think that finance takes priority. And I know it won't be for any of those people that we're delegating to make those decisions, but I think it's sort of worth just recording that we as a board have that responsibility for the patient safety side as well as the financial.
I think the point is well made, and I think any articulation of how we come back onto the plan should be part of keeping board informed if there are any risks, because nobody wishes to take any risk with patient safety at all, and we wouldn't. But I think there needs to be some sort of mitigation or some commentary around the plan, how the plan will not affect patient safety. John.
Yeah.
Thank you, Mark. I just wanted to know what it actually means signing up to the system plan. Is it about what Carol just mentioned about weighing the kind of quality and finance perspective, or is it more around checking whether it is realistically deliverable by the end of the year? As we know that we're already 20 million off target. So and what level of scrutiny we need to apply to what we sign up to. It's more the system context I'm worried about rather than the organizational context.
Robert, do you have I can give a view, but Robert, I think your view is more pertinent.
I think John, the reality is it's both of those, but there's also an element here of aggregating up individual organisations where obviously the boards will be going through the same process we are going through, and understanding how that comes together. There is clearly going to be some quite difficult discussions around trade-offs in terms of what this might mean. Some of this has been in the press to a degree. Some of the things that are clearly there are discussions around how fast or how much progress can be made on waiting lists and things like that, because those are some of the areas that are within the potential gift to think about how quickly you're going at some of those elements. But there's a whole range from a kind of an NHS-E perspective. There's some additional information they're passing out around some of the national programmes that they are now saying may need to be slowed or we may need to look at. So those are some of the details that will be being worked through at the moment by teams. So it is work in progress, but it is both the points you make, John. But we are looking towards, I guess, primarily individual statutory organisations understanding what this means to them and their services, but also taking that at a broader perspective in terms of from a risk perspective across the system.
Thank you. And I think Tessa's put a very pertinent comment in the chat in suggesting some clinical oversight of it seems the signing up is Sarah and I. But I think in that process, I think it would be reasonable to ensure that John and Natalie have a say and an input. I don't want to widen it too wide and make it over cumbersome, but I think it's right to ensure that we take on all views, and that view obviously must be the clinical safety side of things as well. So in that delegations, I think John and Natalie's input would be particularly useful as well. Sarah.
I was just looking at logistics because it's got to be signed off by the 22nd and we don't have it yet, and that's less than a week away. So I was just going to suggest, Mark, if we may, that Rob goes through the latest progress at directors on Tuesday, and if there's any director comments that we need to feed in, we will. And then I'll arrange the separate meeting with the four of us to sign it off. I don't know if Rob, if you know when we're going to see the final product to sign off, because obviously the window of time is quite tight.
Currently there is a system meeting scheduled for Monday.
Okay.
So that is when I'm expecting the next sort of opportunity to draw some of this together. That would work reasonably well with us being able to have a discussion as an executive team on the Tuesday.
Okay, that sounds an ideal way forward. So can I get board's agreement, please? That I don't think board needs to agree that Sarah and I signed off. I think we've been mandated to do so, but I would certainly feel more comfortable with board agreeing the process which has just said is that it's taken to directors to receive all input, including clinical input, before then coming to Sarah, myself, Robert, and Beej to have the conversation to advise Sarah and I to sign off or otherwise. And then on the basis of what is said and known then, an email or communication of some sort will come from Robert to ensure that all board is kept informed of the position as we find ourselves on the 22nd. Can everybody agree to that, please? Yes, looking around the room, all nods, no dissentage. Dissentage, I think I created a word there, dissension. Thank you very much indeed, everybody. Okay, then I know we're pushed for time, but I think that was a particularly important matter that we ensure that we all understood. If we can now push through the rest of the agenda, that would be particularly useful. So moving on to Audit Committee, Martin.
Thank you, Chair. I'll take the papers as read, just pointing out that in relation to our internal audit, where we have mandatory reports around our key financial risks, etc., we continue to get very good responses and significant assurance. And the focus of our other areas in terms of perhaps more clinical areas are where we have concerns, and therefore we expect that they are not necessarily going to come up with significant or full assurance, but they absolutely play to some areas that are key to quality and safety committees. So the one that's highlighted in this month's report were around pharmacy and complaints, and they're part of wider reviews. The only other thing I want to say, firstly, I think the new internal audit collaboration with 360 Audit and the merger has actually expanded their capability to look into some of those clinical areas for us, and we're taking advantage of that. And we are going through the process now with the exec leads and the committee chairs to really hone down what our focus for internal audit is for next year, so that we end up with an internal audit plan that really addresses those areas of concern. Those are the only areas I wanted to bring to the board's attention, but also to congratulate procurement on achieving a real milestone in terms of moving very swiftly and painlessly. I certainly haven't heard much feedback on it, negative feedback, of moving to no PO, no pay, which is, it sounds technical, but actually is a big stride and an awful lot of work for them. And I think they should be congratulated on achieving that. Thank you, Chair.
Thank you, Martin. We will ensure the minutes reflect that. Congratulations, which is right. Any questions for Martin? It doesn't appear so. Thank you, Martin. We'll now move to Carol. Carol, congratulations on your appointment as non-executive director and taking chair of this committee. And I see that you've taken the brevity of report immediately to heart.
We're going for the record, Mark. We're going for the record.
Yeah.
I mean, it's easy in a way, because just a reminder that this committee is quite different from some of the others in that it is we're working towards being a joint committee with the Integrated Care Board, and therefore in some ways things take a little bit more time. But in terms of this report, we didn't actually have our collaborative meeting in November because we took the moment to pause, to work with our partners and work out what the best way forward is going to be. So we will be bringing the formal proposals about how we're going to work with the ICB, and noting that the transfer of functions has been moved to some date in the future, which we will be able to clarify in the future. We'll bring all of that to a future meeting. But I just wanted to add that isn't on in the paper, that it doesn't mean that the collaboration has stopped. We are still working across the system, and that's still happening. And I think we've seen an example of that in the earlier papers about the IAP waiting times, which is certainly something that's been discussed at length at that committee. So I think that's all I wanted to say, Mark. Thank you.
Okay, thank you, Carol. So we can anticipate your next report being slightly longer then, is that the case?
Only a little bit.
Okay, if we can note that, then thank you very much, which then takes us to the Mental Health Ledge Committee, Tessa.
Thank you. Just to say the focus of the meeting was training, so it's a very brief report, nothing significant to highlight to the board.
Any questions at all from anybody? Matthew?
Just a couple of things, really. One was with the advent of PGREF, when we're breaking down data with respect to racialised communities, it would be helpful, I suppose, to see whether racialised communities were over or underrepresented rather than just a raw data. That'd be helpful. And the other point I was going to make is it would probably be useful to understand the percentage of patients detained as a proportion of those admitted, rather than just whether there were more patients detained, because that doesn't mean as much in context.
Thank you, Matthew. I know Jill and Helen were doing a piece of work around the use of some of our protected characteristic data, particularly about Black and minority ethnic groups and under or over representation. So Jill may have something further to add on that, and I welcome your comments about the data and how it could be made more meaningful. So I'm sure Jill and Helen again can take that forward.
Yeah, I saw Jill's thumbs up, which said to me that Roger received and will be acted upon. So thank you very much. If there's nothing else from that committee, thank you. Robert, the annual review of estate strategy. I know this had the tyres well kicked at F&P because I was there for that. Is there anything too much to add to this? But I'd certainly encourage to make sure everybody is ready. It's full of actually quite good news for our patients, in essence, as our estate gets better as well as our staff. Robert?
Not really, just a couple of bits. This is a slightly abridged version from the F&P report, so I'll just commend the F&P report to board members if they haven't had a chance to look through it. And no, Mark, I'd draw out key achievements really are around the Redditch phase of the strategy, which clearly has been a real success story. Dormitory elimination continues. We're now projecting that we should complete the Herefordshire Park Stonebow next summer, with obviously some great facilities delivered in Elgar. We've got a few important projects that are running back end of this year. So Section 136, Hadley works as well. Those are really important from our environment perspective. Those run through. And then right at the end of the report, it just talks about some of the improvements we're making in terms of the things that matter to staff, you know, the accessibility around the new CAFM system, so the new instant logging and repair way we log and feedback to staff. So those are important, and Scott's got some of those within the quality improvement plan. So those would be the key points I'd draw out, Mark.
Thank you, Robert. And I think it's worth saying that at some stage in the future, it'd be quite useful just take 5 minutes to recognise where we've come from and where we're arriving at in terms of our estate around the mental health inpatient provision has been quite significant over what, probably 3 or 4 years, significant improvements. Thank you, Robert. If we could note that, move to Jill and the 6th monthly annual governance statement.
Yes, thank you, Mark. I am very conscious that this is a 26-page report, the actual AGS, although in the interest of research, I did manage to get it down to 6 pages if I do it in font size 2. So perhaps that's what I need to do next time. This is, of course, we are required annually to complete an annual governance statement, which sets out how we assure ourselves of the governance of the organisation with a particular focus on patient safety, quality and clinical effectiveness. And that forms part of our annual report and is also audited by our external auditors when they do the review of the financial statements and quality account. It's good practice to complete an annual governance statement 6 monthly, and actually I do think it is one of those elements that I'm not suggesting that I circulate this more widely through the organisation as a 26-page document, but actually sharing some of the highlights with staff as to how our organisation is governed and how assurance is gained and the various routes to that. And I think it's probably important for some of our staff who have leadership positions to understand some of that. So this report's just presented for information. It obviously contains a wealth of data in terms of the different aspects of our quality assurance framework. I'm happy to take any questions.
Thank you, Jill. Has anybody got any questions? And again, I think with Fee listening in and through Sue, that communication to staff, I think is a good idea. And I think that communications and making sure the right communication to hit the target is used. Can we note that report, please? Thank you very much. Takes us to the reports considered elsewhere. Some good stuff there, and I'd encourage those that haven't accessed them through various other committees to get on diligent and have a look, please. That's the Guidance for Safe Working, Information Governance Report and the Annual Security Report. Thank you. Some number of documents there are sealed. Do we need to know anything about the car parking licence and Redditch Town Hall and the 106 stuff, Jill?
It all relates to the redevelopments in Redditch as a result of us coming out of Smallwood House. So happy to provide any details about it if anyone's interested.
If anybody wants anything, then please contact Jill, who will give you chapter and verse, I'm sure. Thank you. For colleagues to note as well, the 2 appointments with Dr. Radcliffe and Dr. Newton appointed, and I sat on that panel, and particularly impressive consultants are joining us, which is always pleasing to see a widening of the medical workforce. And I think some of that is particularly down to some of John and his team being attractive as a place to go and work, and the method that the medical workforce is managed. So congratulations, John, and your team, I know, that have attracted this type of consultant to come and work for us. Thank you. Any items that we think we've discussed today that needed to be reflected within the board assurance framework? And I do have a couple, Jill, so if your pens... I do wonder how we reflect the risks as Robert articulated around the virtual ward setup moving forward, because, as indicated, we are thoroughly 100% behind this and have recruiting and have staffed at risk as we move forward. And I do wonder, and it's a fundamental part of the ICB's method of left shift. I'd like somebody to have a look at our BAF to check whether it's adequately reflected as a risk to us and the system. Would be one that I would suggest, if that's okay.
I can take that for a discussion to directors to pick that up, and
I'll give the second one because Robert, you wish to comment on this, which is one to come off. At some stage, the risk arranged Stonebow and unforeseen finances will come off. And I wondered, when are we going to be at the stage when we've done all the ground stuff, which I know has caused financial problems, and we've done all the knockdown existing building and tie into existing building, which has caused, I know, your team a number of problems. We must surely be approaching the stage where we've found all the potential problems and we're into the just get on and build within the budget. So on those two issues, Robert, I know you'll perhaps have comment.
Yeah, Stonebow is slightly awkward because it's a phased process. We're still just working towards the final phase. We are actually encountering a few more problems at the moment around where we're bringing two together. My sense is we've probably got another 2 or 3 months to go before we kind of get to the point you're describing, Mark.
Okay, thank you. If we could keep an eye on that one, and then Jill, if you can pick up that other one with whether it be clinical or financial colleagues to see how we reflect that adequately, because it's a system issue as well as a trust issue, I believe. Has anybody got anything else that they thought may have come out of today's meeting at all? Robert?
Yeah, I mean, I think the clear one, we're obviously work in progress, but on the back of the letter, there's clearly going to be potentially impacts on a couple of the BAF risks, and we just need to see where all of that lands. But there's clearly one working in a challenged environment, economy, and then our own sustainability. So those we just need to keep under review.
Yes, I suspect we'll see the BAF amended on that basis for the next time board sits. Okay, if there's nothing else, thank you very much. The date of the next meeting is the 18th of January, once we've had our fill of figgy pudding. And thank you, colleagues, for your time today. We've finished a minute late. Sorry. We meet again for our board development session. I think between 1 and we kick off again at 1:45 once we've all come together. So thank you very much for your cooperation this morning. To colleagues that are listening, I know Martin from Healthwatch is here. If there's anything that comes to mind, Martin, please feel free to contact whomever you think is the right person for any of the information you're seeking on any of the matters discussed. Thank you, colleagues, and I'll see you in person in an hour or so. Thank you very much and goodbye.